Welcome back to the deep dive. Today we're tackling a stack of revision notes you've sent over, focusing on a really common topic. Herpes simplex virus, or HSV.
That's right, a big one for sure.
Our mission, as always, is to unpack these notes together, pull out those high-yield nuggets, and give you a solid breakdown. Perfect if you're revising or just want to get your head around HSV. These notes cover the basics, what it is, how it spreads, symptoms, management, the whole lot.
Straight from the source material you're working with.
Exactly. Think of this as your shortcut through these specific notes. Okay, let's dive in. All right, first things first. According to these notes, what exactly is HSV?
Okay, so right at the top, the notes define it as a double-stranded DNA virus. Pretty standard start.
DNA virus. Got it.
They immediately flag it as, well, very common. And while it's often labeled a sexually transmitted infection, or STI.
Which it is, often.
Right. But the notes make a point of saying it spreads through both sexual and non-sexual contact. That seems like a key distinction they want to highlight early on.
Yeah, that's important. Not just sexual transmission. Okay, so what about its behavior? The life cycle, what do the notes say there?
This is where it gets quite interesting based on the notes. They describe a cycle. Starts with a primary infection, your first encounter with the virus.
Okay.
Then it doesn't just clear up, it enters latency. Basically, it hides.
Hides where?
In the neuronal ganglia, nerve clusters, essentially. And the notes stress this establishes a lifelong infection right there in the nerves.
Lifelong.
Yeah.
Hiding in the nerves. Okay, that explains the recurrence aspect, I guess. It comes back.
Exactly. That's the next stage, periodic reactivation. The virus travels back out from those nerve ganglia.
Back to the original spot.
Usually, yeah, or nearby. And this causes symptoms. But here's a really crucial bit the notes highlight. This reactivation can happen without any symptoms. No sores, nothing visible. It's called asymptomatic shedding.
Oh, okay.
And the notes flag this specifically as a major way it gets transmitted. People can pass it on without even knowing they're having an outbreak.
Right, that's huge for transmission. Okay, so primary infection, latency in nerves, reactivation with or without symptoms, and that asymptomatic shedding risk. And the notes talk about two main types.
They do. HSV1 and HSV2, they mention you need specific testing to tell them apart.
All right.
And clinically, the notes point to things like oral ulcers, genital ulcers, even ocular ulcers in the eye. They mention transmission is mainly via body fluids, especially sexual intercourse, but also general contact.
And they made a point about genital herpes specifically.
Yes, absolutely. The notes clearly state genital herpes can be caused by either HSV1 or HSV2.
So you can't just assume based on location alone.
Exactly. Though there are typical patterns, you need the test to be sure. The notes mention painful ulcers as a sort of hallmark.
Okay, painful ulcers, different sites, two types with overlap, hides in nerves, spreads even without symptoms.
Yeah.
Got that base covered from the notes. Let's talk transmission in a bit more detail, the etiology as the notes call it.
Right, so building on what we just said, the notes get more specific about the main routes for each type.
Okay, let's get specific for revision purposes here. What do the notes say?
All right, HSV1, primarily transmitted through oral-to-oral contact. Think cold sores, kissing, maybe sharing drinks, that sort of thing.
Right.
HSV2, primarily transmitted through sexual contact. Genital-to-genital or oral-genital.
Oh, like the overlap.
Exactly. The notes reinforce that both types can be spread through general skin-to-skin contact with an infected area and through infected bodily fluids. So HSV1 can cause genital herpes and HSV2 can cause oral herpes even if it's less typical.
That overlap is definitely a key revision point from these notes. Okay, so knowing how it spreads, who's more likely to get it, what about risk factors listed in the notes?
The notes list a few key ones. Having multiple sexual partners mentioned.
Makes sense.
Engaging in unprotected sex. Having a weakened immune system, being immunocompromised, and also having a history of previous HSV infection or other STIs.
Okay, those seem straightforward. But do the notes clarify if these are risks for catching it initially or for having worse outbreaks or more recurrences?
That's a really good point. Reading these notes, they just list them as general risk factors for HSV infection. They don't explicitly differentiate between risk of acquisition versus risk of severity or recurrence.
So based just on these notes, we take them as general risk factors. Understood. Okay, let's dig into the actual process. The pathophysiology. How does the virus set up shop once it gets in?
Right, the mechanism. The notes explain it like this. The virus gets in through tiny breaks in the skin or through mucous membranes, like the lining of the mouth or genitals.
Okay, finds a way in.
Then it starts replicating, making copies of itself right there in the epithelial cells. Those are the surface cells. This initial replication is what usually causes that first sore or blister in the primary infection.
So the first fight happens at the door, basically.
Pretty much. But it doesn't stop there. The notes explain it, then travels.
Ah, here's the nerve part again.
Exactly. It travels along the sensory nerves, moving away from the entry site, up to the nerve cell bodies, which are clustered in those sensory ganglia we talked about.
Right, the hiding place?
That's where it establishes its lifelong latent infection. It essentially goes dormant, hiding from the immune system within those nerve cells.
Fascinating. That journey up the nerve to the ganglion. And reactivation is the return trip.
Precisely. The notes say periodic triggers. They don't detail the triggers in these notes, but things like stress, illness, sunlight are common ones cause the virus to wake up.
Right.
It then travels back down the same nerve pathway to the skin or mucous membrane surface near the original site, causing a recurrent outbreak, those sores, blisters, etc.
So up the nerve to hide, down the nerve to cause trouble again.
Yeah.
A round trip. Got it. Now, those symptoms, the sores, someone comes in with something that looks like HSV. What else could it be? What do the notes suggest for the differential diagnosis?
Good question. The notes list several things to consider, especially if you see ulcers or blisters. Other STIs are definitely on the list.
Okay.
They specifically mention syphilis, chancroid, and genital warts. So ruling those out is important.
Other infections primarily.
Mostly, but not exclusively. The notes are careful to add non-infectious possibilities, too.
Oh.
Things like contact dermatitis, which is basically an allergic reaction or irritation on the skin, or recurrent aphthous ulcers, which are common mouth sores, sometimes called canker sores.
So you can't just jump to conclusions based on appearance. Need to consider these other possibilities listed in the notes. Good point for revision. Shifting gears slightly, what about how common this is? Do the notes give us any epidemiology, any numbers?
They do give some figures, focusing on the 15-64 age range. For HSV2, the genital herpes type primarily, the notes state it affects about 1 in 10 people in that group.
1 in 10, okay.
But for HSV1, the type usually associated with cold sores, it's way more prevalent. The notes estimate over half the population in that age range is infected.
Wow, over half for HSV1. That's a lot.
It's a huge difference, isn't it? And the notes kind of implicitly link this back to how they're transmitted.
How so?
Well, HSV1 spreading mainly oral to oral, often picked up in childhood non-sexually. It's, family contact. Sharing things means it just spreads much more widely through the general population.
Right, more casual contact opportunity.
Exactly. Compared to HSV2, which is primarily sexual transmission, leading to that lower, though still significant, prevalence of 1 in 10, the notes sort of paint that picture through the transmission details.
That makes sense. The route explains the prevalence difference noted. Okay, let's focus on what the infection actually looks like, the clinical features in the notes. What are the key symptoms?
The classic description in the notes is painful, fluid-filled blisters or sores, vesicles, technically.
Painful blisters. And location matters, according to the notes.
Yes, they state the typical pattern. HSV1 usually affects the mouth area, cold sores, fever blisters. HSV2 usually affects the genital or anal region.
But remembering that overlap we discussed.
Absolutely. Always remember the overlap. Either type can technically cause infection at either site.
Okay. Are there other symptoms mentioned besides the sores?
Yes, the notes mention additional things, especially with the first primary infection. Itching or a tingling sensation often comes before the sores appear. That's sometimes called a prodrome.
A warning sign?
Kind of, yeah.
Okay.
And you might also get flu-like symptoms. Fever, body aches, headache, swollen glands sometimes.
And the notes mention specific factors clinicians use to help diagnose, not just the symptoms alone.
Right. They state diagnosis often involves putting together the typical symptoms with the patient's risk factors.
Which risk factors do they list here again?
They reiterate some of the ones we mentioned earlier, being immunosuppressed, high-risk sexual behavior, having HIV, being female, non-Caucasian race, and increasing age are all listed in the notes as factors considered in the diagnostic picture.
Okay, so it's the whole clinical picture.
Mm-hmm.
The sores, maybe the prodrome, possibly flu-like stuff initially, combined with those background risk factors.
Yeah.
Given that, how is it confirmed? What investigations do the notes list?
So how do you actually test for it? The notes list 3 main methods. First, viral culture. You take a swab from one of those fluid-filled blisters and try to grow the virus in the lab. The notes say this detects the live virus and is best when lesions are fresh and actively weeping.
Right. Need an active sore for that one. What else?
Second, HSV polymerase chain reaction, or PCR. The notes describe this as more sensitive than culture.
More sensitive how?
It detects the virus's genetic material, its DNA. It can pick up the virus even when there isn't much live virus present, like when lesions are starting to heal, or sometimes even from spinal fluid if there's a concern about meningitis. It measures viral copies.
This potentially more useful in some situations. And the third?
The third is glycoprotein G-based type-specific serology. That's a blood test.
Ah, looking for antibodies.
Exactly. It doesn't detect the virus itself, but the antibodies your body makes against the virus. The key thing the notes highlight is that it's type-specific. It can tell you if you have antibodies to HSV1 or HSV2 or both.
And that works even without current symptoms.
Yes, that's the advantage. It can show past infection or exposure even if you have no lesions at the time of the test. Useful for identifying carriers or confirming a diagnosis when presentation isn't clear.
Okay, so culture or PCR for active virus, serology for past exposure antibodies. Makes sense. Once it's diagnosed, how is HSV managed according to these UK context notes? What's the strategy?
The primary approach listed is antiviral medication. The notes give examples like acyclovir, valacyclovir, and famciclovir.
Right, the standard antivirals. And what do they do?
Their purpose, according to the notes, is several things. Reduce the severity and duration of outbreaks when they happen. They can also suppress viral shedding.
Which helps reduce transmission risk.
Exactly. And for people with frequent recurrences, the notes mention these drugs can be taken daily, that's suppressive therapy, to prevent or reduce the number of outbreaks.
Okay, antivirals are key. What else do the notes mention for management?
They explicitly list safe sexual practices, specifically mentioning condom use, as vital for reducing transmission risk.
Practical advice. Good.
They also mention topical antiviral creams as a second-line option for oral infections, so cold sores. And for immunocompromised patients who might have more severe or drug-resistant infections, the notes list foscarnet as a second or third-line option for oral or genital HSV.
So more options for specific situations.
Yes. And finally, a really important component mentioned in the notes is patient education, helping people understand their condition, how to manage symptoms, how to reduce transmission risk. That's listed as a core part of management.
Right, empowering the patient. Okay, antivirals, safe sex, maybe topicals or foscarnet, and education. Got it. What about the long term? What's the prognosis according to these notes?
The notes are very clear. HSV infection is lifelong. Once you have it, the virus stays latent in those nerve ganglia forever.
No cure of that.
No cure are mentioned in these notes. However, they do state that with proper management using the antivirals, safe practices, most people can live healthy lives with the symptoms being well controlled.
That's somewhat reassuring. Did the notes mention complications?
They did. They preface it by saying severe complications are rare, but then there's a slightly interesting phrasing. They add, especially in immunocompromised individuals.
What do you make of that phrasing?
Well, it could mean complications are rare overall, but when severe ones happen, they are more likely in immunocompromised people. Or perhaps it's just emphasizing that this group needs particular vigilance. It's specific wording from these notes worth clocking.
Okay, noted. So even if severe ones are rare for most, what are the potential complications listed?
The notes list a few. One is the virus spreading to other parts of the body.
Like where?
Examples given are the eyes causing ocular herpes, which can be serious for vision, or the fingers, which is called herpetic whitlow, often seen in healthcare workers or children who suck their thumbs.
So it can move beyond the initial site. What else?
Recurrent symptom outbreaks themselves are listed as a complication, which makes sense given the chronic nature. The notes also state that having HSV, particularly genital HSV, increases the risk of acquiring or transmitting other STIs, including HIV, possibly because the sores create an entry point.
That's a significant public health link.
Definitely. And finally, a major one the notes mention is neonatal herpes. If a pregnant person has an active outbreak or asymptomatic shedding around the time of delivery, the virus can pass to the newborn.
That's serious for the baby.
Extremely serious, yes. The notes highlight it as a potential complication. It can cause severe illness and long-term problems for the infant.
A critical point, especially in a clinical context. So spread, recurrences, increased STI risk, and neonatal herpes are the complications outlined here. Okay, so that covers the notes pretty thoroughly, I think. Definitions, spread, risks, how it works, what else it could be, how common it is, symptoms, tests, management, outlook, and complications. It really takes you through the whole story of the condition according to this material.
Exactly. And if you boil it down, the key takeaways from these notes seem to be it's very common, especially HSV1. It's lifelong because it hides in the nerves. Management with antivirals is effective for symptoms and reducing shedding. And remembering that asymptomatic shedding is a major driver of transmission is crucial.
Absolutely. That asymptomatic shedding point really sticks out as explaining why it's so widespread, doesn't it? People spreading it without even realizing.
It does, and that actually raises a broader question, thinking beyond just these notes, given how common it is, and the silent spread. What does that mean for public health? Are individual treatments and advice enough? Or does it point towards needing different strategies, something to mull over as you continue your studies?
That's a fantastic point to consider. If you found this walkthrough of your revision notes helpful and you're looking for more structured resources, especially for exams.
And definitely check out PassTheMSRA.com. It's designed for exactly this kind of high-yield preparation.
And don't forget the free resources available over at freemsra.com as well. Worth exploring. Right, that brings us to the end of the deep dive into the HSV notes. We hope breaking it down like this was useful for your revision and understanding.